Okay, so this is the second lecture on advanced life support, and in the first lecture we learned the following things. We learned how to recognize a cardiac arrest. Then we also learned how to approach safely a victim who has a cardiac arrest, how to open the airway, and how to check for breathing, and how to start resuscitating with chest compressions and breaths. And in this lecture, we will try to concentrate on how to support circulation by chest compressions, defibrillation, and administering drugs. Right, so in this lecture, we will learn how to deliver chest compressions, how to defibrillate, and also setting up an IV cannula and an IV drip, importance of leg elevation, and the drugs that have to be delivered in a advanced life support. And namely, the drugs are adrenaline and amiodarone. So, adrenaline you will be giving 1 milligram after the third shock for ventricular fibrillation or ventricular tachycardia, or you will be giving 1 milligram as early as possible for non-shockable rhythms like asystole or pulseless electrical activity. And thereafter, you have to give adrenaline every 3 to 5 minutes for both types of cardiac arrests. And amiodarone 300 milligrams would be administered for shockable rhythms, ventricular fibrillation or ventricular tachycardia, for shockable rhythms which are resistant to defibrillation, and generally no other drugs are used on a regular basis in advanced life support, and atropine has no longer a place in advanced life support. Okay, now have a look at these diagrams. So the both diagrams show chest compressions and on a cross section of the chest. So on both sides, either sides, you have a cross section of lungs, and in on the top front you have the heart, and above that is the sternum, and at the bottom is the vertebral column. So when a resuscitator rescuer is compressing on the sternum, you are pressing the heart and you are trying to squeeze the heart between the sternum and the vertebral column, thereby compressing the heart and promoting a cardiac output. And at the same time, when the rescuer is taking the hands off or releasing the pressure, we are encouraging a venous return into the heart. And with the next compression, again with compressing of the chest, blood is ejected out of the heart. Right, so out of all these things mentioned above, chest compressions are the most important intervention of all. So during resuscitation process, during advanced life support CPR, you should try your best to interrupt chest compressions only minimally. Unless it is essential, you are not going to stop chest compressions, you are not going to interrupt chest compressions. Right, now for chest compressions, where do you keep your hands? So you have to interlock your hands. So using one hand is not enough for resuscitation in an adult. For a neonate, you may use your one of your fingers, thumb or single finger. For a bigger child, you may use your two fingers. For a child who is bigger, you can use three, four, five fingers, maybe one whole hand. But when it comes to adults, you have to use both hands. So interlock both hands together and place the two hands, the palm of the hands, in the middle of the lower half of the sternum. So you get the sternum from jugular notch to xiphisternum is the length of the sternum. Get the lower half. Place the two hands on the middle of the lower half of the sternum. So you need to deliver high quality chest compressions, minimally interrupted. So don't stop or interrupt chest compressions for various things. So continue chest compressions while a lot of other things are happening, including while the defibrillator is being charged. And you can take your hands off, you can stop chest compressions when defibrillation is going to happen. So if you are going to pause chest compressions, if you are planning to stop chest compressions for a purpose, it has to be for an essential purpose. Plan for it. And during resuscitation practicing, you will realize delivering chest compressions is not easy, and the person who delivers chest compressions becomes very tired, can become exhausted. So other members of the resuscitation team has to take turns in delivering chest compressions. A single person cannot continue to provide chest compressions. Right, so this is how you deliver chest compressions. When you compress, you have to compress the chest to a depth of 4 to 5 centimeters for these compressions are to be effective. So what is the rate of compressions? 100 to 120 compressions per minute. So don't compress too slow at a lower rate, then compressions are not effective. At the same time, do not compress at a faster rate, then what happens is venous return is reduced. So you have to leave some time for the heart in diastole for heart to get filled with blood. Thereafter only your compression is going to be effective, otherwise you will be squeezing an empty heart. Right, now to negate the exhaustion factor, there are cardiac support pumps, non-invasive cardiac support pumps. Of course, these are not very frequently used; those are very expensive. So, in these, when you use these support pumps, you place it over the patient's chest. Now, there's a board and a pump, so you keep the patient's back on the board, and so the patient lies on the board, and there's a band that tightens across the chest, and you set it like this, and then you switch it on. The machine will compress the chest as if you are doing chest compressions. So some more stuff about non-invasive cardiac pumps. So one brand is Autopulse, and there you can place the victim like this, and the patient's back is lying on the board, and when you switch it on, this will deliver chest compressions. And another advantage of using non-invasive cardiac support pumps is you can continue to give chest compressions even during transferring of a person. Right, so this is an Autopulse cardiac pump. Now look, these are not frequently used. I haven't used anything. I haven't seen these pumps being used even in the developed world. So even in the developed world, rescue team members or resuscitators do manual chest compressions. So these are automated, so computerized, portable, battery powered, more efficient than the human hand because this negates the exhaustion factor. So those are very useful during procedures where person who is in a cardiac arrest is undergoing procedures like angiography or CT scan. And it is quite useful for prolonged resuscitation, like in hypothermia and poisoning, where we will have to resuscitate the victim for several hours at times. So then obviously the exhaustion factor is going to come up. So that can easily be negated with a cardiac pump like this. That when you have a single rescuer, like what is seen here, now see in this photograph I'm trying to show how mouth to mouth breaths were delivered. So these were things that were done a long time back, but now these have gone out of fashion. Now with the COVID concerns, we are no longer going to deliver mouth to mouth breaths to anybody. And you can see in the next diagram, this rescuer is delivering chest compressions to a smaller child. So the rescuer has to adjust the force that he is going to exert on the child, otherwise he will be doing more harm than good to this child. By he might break ribs. There can be laceration of the myocardium or pericardium, or even pulmonary lacerations due to broken ribs. Now This is to show if there's only a single rescuer to resuscitate the cardiac arrest victim. So the rescuer has to deliver chest compressions and to attend to breathing. Now, so this is something that was done a long time back, well before COVID concerns. So now, giving mouth-to-mouth breath is out of question. And well, if you have an ambu bag and a face mask, instead of doing breaths like this, you can do deliver a breath. But now, what is recommended in a situation like this is to deliver compression only, uh, life support, and the authorities do not talk about delivering breaths. Right now, how are you going to defibrillate? So this is a rather older type of defibrillator machine. So this is the machine. You take the two pedals. So now these are defibrillator pedals. If this is the cardiac arrest victim, place one pedal over the apical area, over the apex of the heart. Place the other one on the right side. So we generally prefer to place the other pedal just below the clavicle of the right side. So right subclavicular area. You may place it on just lateral to the sternum as well. So when you defibrillate, what happens is a coordinated large shock or large energy goes through the heart like this, and thereby we are trying to defibrillate the heart and trying to regularize the rhythm of the heart. Right, so when you use a defibrillator and defibrillates, what happens is you are trying to depolarize a critical mass of the heart muscle, the myocardium, and to terminate the arrhythmia. And that will allow normal sinus rhythm to be re-established by the body's natural pacemaker, which is the SA node or the sinoatrial node. Right, in defibrillation, in the previous photograph I showed defibrillation using pedals. So what the resuscitator was placing on the chest were pedals. Instead of pedals, you can use pads. So these are two pads. You break open the cover, take the pad out now. So this is the cover. You have to break it open, tear it open, and take the pads out. These are the pads. This is the automated defibrillator, and you can paste these on the chest, one over the apex of the lung, the other just below the right clavicle. So now these defibrillators are called automated external defibrillators. Now why do we call these automated? So there are mini computers there. So when you attach the pads to the victim, through the pads the machine will detect the rhythm of the cardiac arrest, whether that is a shockable rhythm or non-shockable rhythm. If it is a shockable rhythm, whether this is a VF or VT, so that is detected by the machine, and that will give a verbal prompting. So the speaker of this machine would say, okay, so the sensors are in the pads. So pads are used for sensing the rhythm and for delivering the shock, for both. So then the machine will detect what this is, because it is sensing through the pads what the cardiac rhythm is, and would say, for instance, it might say, okay, so this is a shockable rhythm, please stand away, I'm charging the defibrillator now and will be delivering in a few seconds. And then in a few seconds it will say, okay, I'm delivering energy, do not touch the patient, stand away. So then the resuscitators should stand away without touching the victim. So if you touch the victim when a defibrillation current is being delivered to the patient, you will also get electrocuted, you will also get a shock, and that might push you into a cardiac arrest. So you have to remember to not to touch the victim when uh, during defibrillation. And it's the responsibility of the person who defibrillates also to look at the whole length of the victim to make sure no one else in the resuscitation team is touching the victim. So defibrillation going public, especially with using of automated external defibrillators. Now, so in the developed world, they are talking about public access defibrillation. So automated external defibrillators are placed in places where there are large gatherings of humans, say large soccer stadiums, large rugby stadiums, or large beaches, especially where a lot of people would come to swim or dive, especially on weekends or on holidays. And also sometimes near swimming pools or airports. Again, automated defibrillators are placed. So, in case of a unfortunate event where somebody has got drowned after bringing the person to the bank of the swimming pool, you can easily attach two pads of the defibrillator and deliver shocks. So, how much of current are we going to deliver? So there are two types of defibrillators. Modern ones are biphasic defibrillators. The older ones are monophasic defibrillators. So with biphasic defibrillators, we can try to deliver a lower amount of energy. So then uh, burn injury to the heart and the rest of the body is less. So first shock can be given as 150 to 200 joules. Second shock and subsequent shocks can be given as 360 joules or the maximum energy level shown in the defibrillator. Now for the older type of monophasic defibrillators, we have to deliver about 360 joules. Now this is a picture of a defibrillator. You can see there are two pedals. This is a tube of gel that has to be used for lubrication purposes. This is the monitor. This is the dial. So you can switch on the machine here. These defibrillator machines are available in our ICUs. You can go and have a look, or when you are in the intensive care unit, just have a look at these defibrillators. So this is the switch to switch it on. Using this dial, you can set the energy level to, let's say, 50 or 100 or now for instance, I told with the modern biphasic defibrillator, you use an energy level with between 150 to 200. So you can set it here. Then you put it for charging, and once it is charged, you bring the two pedals over to the patient's body, place one on the apex, place the other one just below the right clavicle, and then deliver. So before delivering, you look at the monitor again to make sure that the rhythm is still a shockable rhythm, and also look at the head end, the two sides of the victim, and the foot end to make sure no one else in the resuscitation team is touching the patient. And so this is what happens when you place the two electrodes, the two pads or pedals like that, and deliver a current. There will be a critical level of energy current going through the heart. So, what are the drugs that you will be using during an advanced life support? As I mentioned earlier, the most important drug is adrenaline. You will be using 1 milligram, so you can't afford to forget the dose. And there's no time to learn the dose during resuscitation, so you have to remember the dose, and the dose is 1 milligram. So, you take 1 milliliter of 1 in 1000 adrenaline, and that is 1 milligram, and you have to deliver it after the third shock when it comes to shockable rhythms like VF and VT, or if it is an asystole or pulseless electrical activity, deliver 1 milligram as early as possible. And thereafter, you have to deliver adrenaline every 3 to 5 minutes in both types of cardiac arrest. And the other important drug for regular use in an advanced life support is amiodarone, which is used for shockable rhythms like VF and VT, where you will be using 300 milligrams for resistant ventricular fibrillation and pulseless VTs. So there's no place for atropine in advanced life support algorithm. And so now you have to use equipment, correct equipment of correct size during a CPR or advanced life support. Now, for instance, if your victim is a very small one like this, you can't use an ordinary big laryngoscope or big endotracheal tube on this child. So you have to have the correct size laryngoscope. So the Standard size for an adult would be, average built adult would be size 3 laryngoscope blade. For a neonate, it will be 0 or double 0 size laryngoscope blade, and the endotracheal tube would be 2.5 or size 3, whereas for an adult, it will be 7.5 or 8. You also need to know a few things about post resuscitation care. So, now what do we mean by post resuscitation care? Now, there was a victim who had a cardiac arrest. You have resuscitated him, you have got spontaneous circulation. We call it ROSC, return of spontaneous circulation. And now you have to try and continue to support the heart and breathing till the patient recovers from the correctable or reversible cause. Now, so there are a few things that you have to pay your attention to. One is, while avoiding hypoxia, you have to avoid hyperoxia also. So titrate your inspired oxygen concentration to get a saturation between 94 to 98. Don't give too much of oxygen. Don't leave a patient on 100% oxygen for a long time. 100% oxygen itself is toxic to a patient. So a patient who has got a cardiac arrest due to heart attack, acute coronary syndrome, will need coronary intervention. So primary percutaneous coronary intervention should be done when applicable. So you have to maintain glycemic control. So treat if the random blood sugar is more than 10 millimoles per liter. And so you have to avoid hypoglycemia and hyperglycemia both. So some patients will benefit from therapeutic hypothermia, because when you bring the temperature down of the body, oxygen requirement of the heart and the brain and rest of the organs will also come down. Right, now we have come to the last slide of the lecture, and there's increased emphasis on capnography with advanced life support. Now, in the previous slides, we learned that during advanced life support, we are using several medical equipment. One is a defibrillator, maybe a multi-para monitor, maybe a pulse oximeter. Then you are using IV drips, and another very important equipment is capnometer, which will show a capnograph. So now what do we do with a capnometer? So when you attach a capnometer to a patient, you attach the airway adapter of the capnometer to the endotracheal tube. Let's say you have intubated a patient using a laryngoscope and an endotracheal tube. Now the endotracheal tube is in the trachea, just above the carina, and therefore when you deliver breath, breath would be delivered both to right and left lungs. Now, when the patient exhales, expires, breath will come through the endotracheal tube from the lungs and will go down the breathing tube, and a small sample of it would be taken up through the airway adapter of the capnometer and will be drawn into the capnometer machine. So using that sample of air that is drawn into the capnometer machine, the machine will calculate how much of carbon dioxide is in this expired gas. So if there's a satisfactory amount of carbon dioxide in the capnograph, that means there's adequate ventilation happening. And at the same time, where does this carbon dioxide come to the lungs? So carbon dioxide is brought to the lungs by blood. So blood will collect carbon dioxide from peripheral tissues. Carbon dioxide that is produced in metabolic process. Carbon dioxide is a metabolic waste product. So that will be washed with peripheral perfusion. So arterial blood will bring oxygenated blood to peripheral tissues. From peripheral tissues, blood with less oxygen but more carbon dioxide will be collected by venous blood, and that venous blood will come to the heart as venous return. Then it will go to the lungs through pulmonary circulation, and that carbon dioxide will be exhaled through lungs after gaseous exchange. So finally, the gas sample that you are seeing in the expired gas is representing a lot of systems in the body. One system is the integrity of the endotracheal tube and rest of the breathing circuits. Another thing is the type of ventilation happening at the lung level. So ventilation has to be reasonably good for carbon dioxide exchange to take place. Then the kind of venous return that is happening. So it is the venous return that brings carbon dioxide from peripheral tissues into the lungs. Then it gives an idea about the contractility of the heart also. Right, so as I mentioned earlier, capnometer or the capnograph will confirm correct placement of the endotracheal tube. So normal EtCO2 in an otherwise healthy person when he is intubated, the normal capnography reading would show an expired carbon dioxide tension of about 40 to 45 millimeter mercury. So if you place the patient's endotracheal tube in the correct place is the trachea, you will see the correct figure of the graph also. Whereas if you have accidentally done an esophageal intubation, that can happen in a difficult intubation, instead of the tube going through the vocal cords to the trachea, it will go down the esophagus. Then you will not see a capnograph on the capnometer, and you can be sure that you are not in the trachea, which is a mishap. So the tube has to be pulled out again and try to be intubated into the trachea. Then by following the capnograph or the capnometer reading, you can continuously be sure about the placement of the ET tube. Now, for instance, during chest compressions and during various other maneuvers you do during advanced life support, the endotracheal tube can get dislodged. So, by following the capnometer reading or the capnograph, you can again be sure that the endotracheal tube is still in place in the trachea. Then also uh, getting a reasonably good end-tidal carbon dioxide reading, something above 15 to 20 millimeter mercury, generally give an assurance that there's reasonably good quality chest compressions is going on. Then capnograph is also useful to indicate return of spontaneous circulation, ROSC. So this brings my lecture to end, and in this lecture we discussed about largely on measures that we take to support the circulation. And in the first lecture we largely learned measures that we do to open the airway, to maintain the patency of the airway, and how to deliver breaths. Thank you very much.